This is Kathy Knipfer, instructor for Nursing 2203, recording the Pediatric lecture for Chapter 40, Respiratory Dysfunction. Let's talk about the anatomy of the respiratory tract. The upper respiratory tract consists of the oronasopharynx and the pharynx, as well as the larynx and the upper trachea. The lower respiratory tract consists of the lower trachea, bronchi, bronchioles, and alveoli. Infectious agents that can cause respiratory infections are viruses such as respiratory syncytial virus, or RSV. Others include the group A beta hemolytic streptococci, staphylococci, Haemophilus influenza, Chlamydia trachomatis, Mycoplasma organisms, and pneumococci. For infants under the age of 3 months, they are protected by maternal antibodies. From 3 to 6 months, the infection rate increases. Toddlers and preschool-age children have a higher rate of viral infections. If they're older than 5 years, there's an increase in Mycoplasma pneumoniae and beta hemolytic streptococci infections. Immunity increases with age. The diameter of airways are smaller with children. The distance between structures is shorter, allowing organisms to move rapidly. Eustachian tubes are short and open, allowing for infection to occur in the middle ear. Conditions that decrease resistance to infection in children are problems with the immune system, malnutrition and anemia, allergies and asthma, preterm birth, cardiac anomalies, diseases like cystic fibrosis, and also the exposure when they go to daycare. The most common respiratory pathogens appear in epidemics during the winter and spring months. Mycoplasmal infections occur more often in fall and winter. Infection-related asthma occurs more frequently during cold weather, whereas winter and spring are typically the RSV season. Clinical manifestations of respiratory infections vary with age. The generalized signs and symptoms and local manifestations differ in young children. They might have fever and meningismus. Meningismus consists of nuchal rigidity, photophobia, headache, but they don't have an infection in the meninges. These symptoms subside as the temperature decreases. They also might have anorexia, vomiting, diarrhea, and abdominal pain, as well as a cough, sore throat, nasal blockage, or discharge. Also, there may be abnormal respiratory sounds, and wheezing, crackles, or an absence of air movement on auscultation. Care management of respiratory infections includes interventions to ease respiratory effort, to promote rest and comfort, to prevent the spread of infection, to reduce temperature, to promote hydration and nutrition, and provide support and reassurance. Nasopharyngitis, otherwise known as the common cold, is caused by numerous viruses. It might be caused by the RSV, rhinovirus, adenovirus, influenza, and the parainfluenza viruses. Fever would vary with the age of the child. These patients can be managed at home, and there is no specific treatment. Acute streptococcal pharyngitis is caused by group A beta hemolytic streptococcal infection. There is a risk for rheumatic fever. Clinical manifestations include pharyngitis, headache, fever, abdominal pain, possibly inflamed tonsils and pharynx. Diagnostic evaluation would be through the use of the rapid identification test and throat culture. Usually it's treated with oral penicillin or erythromycin. These patients are infectious until they have taken antibiotics for 24 hours. After antibiotics have been taken for 24 hours, toothbrushes should be discarded. They should avoid sharing drinking and eating items and they will need pain management. This is what acute streptococcal pharyngitis looks like. Tonsillitis frequently co-occurs with pharyngitis. It can be caused by a virus or a bacteria. Clinical manifestations of tonsillitis are caused by inflammation. The tonsils become edematous. The inflammation and the edema causes obstruction of the pathway for air and food. Tonsillitis is self-limiting. Treatment of viral pharyngitis is symptomatic. Positive throat cultures warrant antibiotic treatment. It's important to differentiate between viral and streptococcal infections. Because most infections are of viral origin, early rapid tests can eliminate the administration of unnecessary antibiotics. Tonsillectomy and adenoidectomy may be indicated with recurrent abscesses, airway obstruction, repeated tonsillitis, 3 or more tonsil infections per year, persistent foul taste or breath caused by chronic tonsillitis, unilateral tonsillar hypertrophy, chronic tonsillitis in a streptococcal carrier. Adenoids are commonly removed when a tonsillectomy is done, especially if they've been hypertrophied and they obstruct nasal breathing. After tonsillectomy, until the child is fully awake, they are placed on their side or abdomen to facilitate secretion drainage. Routine suctioning should be avoided. When they're alert, they can sit up. They should be discouraged from coughing frequently, clearing the throat, blowing the nose, and any other activity that might aggravate the operative site. Some secretions are common, but we want to inspect them and vomitus for evidence of fresh bleeding. Most children experience moderate pain after a tonsillectomy and adenoidectomy. The throat is definitely sore. Ice collars may help, but they will need analgesics that are administered regularly. Postoperative hemorrhage is uncommon but can occur in up to 5% of patients up to 14 days after surgery. So you would want to look for tachycardia, pallor, frequent clearing of the throat or swallowing by a younger child, vomiting of bright red blood. Restlessness, an indication of hemorrhage, may be difficult to differentiate from general discomfort after surgery. If continued, influenza, commonly known as the flu, is caused by orthomyxoviruses types A, B, and C. Clinical manifestations of influenza include dry throat and nasal mucosa, dry cough, tendency toward hoarseness, flushed face, photophobia, myalgia, and sudden onset of fever and chills. Therapeutic management includes fluids, symptomatic treatment, possibly amantadine hydrochloride to reduce symptoms, prevention through vaccination. Nursing care for influenza is the same as for any child with an upper respiratory infection. This includes implementing measures to relieve symptoms. The greatest danger is the development of a secondary infection. These secondary infections could be bacterial and should be reported to the healthcare practitioner so that antibiotic therapy can be initiated. And as you know, children with influenza or other similar viruses, otitis media is primarily a result of malfunctioning eustachian tubes. Common bacteria that might cause acute otitis media are Streptococcus pneumoniae or Haemophilus influenza. Diagnosis is made through careful assessment of the tympanic membrane with a pneumatic otoscope. Clinical manifestations of acute otitis media might be ear pain, fever, and possibly purulent drainage. It often follows an upper respiratory infection. Clinical manifestations of otitis media for an infant or a very young child might include crying, fussiness, restless, irritability, a tendency to rub, hold, or pull on the affected ear, rolling the head from side to side, difficulty with comforting, refuses to nurse or take a bottle, and a loss of appetite. With older children, they might cry or verbalize feelings of discomfort. They also might be irritable, lethargic, and also lose their appetite. Chronic otitis media might result in hearing loss, difficulty communicating, and possible feelings of fullness, tinnitus, or vertigo. Treatment for acute otitis media involves a prescription for antibiotics. Amoxicillin is the treatment of choice. Otitis media may also be treated surgically. That would include myringotomy with tube placement and possibly an adenoidectomy. Nursing care for children with acute otitis media includes relieving pain, facilitating drainage, preventing complications or recurrence, and educating the family in care of the child. The nurse should emphasize that all of the antibiotic medication should be taken. To prevent recurrence, mothers should be encouraged to breastfeed for at least 6 months, avoid bottle propping, decrease or DC the pacifier after. Infectious mononucleosis is caused by the herpes-like Epstein-Barr virus, or EBV. Diagnostic tests for infectious mononucleosis include the Paul Bonnell or the monospot. The monospot allows for earlier diagnosis and is more convenient. There is no specific treatment for infectious mononucleosis other than analgesia and rest. The prognosis is usually self-limiting and uncomplicated. Often there is persistent fatigue. It subsides within 2 to 4 weeks and usually does not extend past 3 months. Nursing care involves a careful assessment of the swallowing ability and also to detect serious airway edema and airway compromise. Croup syndromes are characterized by hoarseness, a barking cough, inspiratory stridor, and varying degrees of respiratory distress. Croup syndromes affect the larynx, trachea, and bronchi. The types include epiglottitis, laryngitis, laryngotracheobronchitis, or LTB, and tracheitis. They are most often caused by Haemophilus influenza type B. Acute epiglottitis is a medical emergency because of the obstruction that occurs. Clinical manifestations include sore throat, pain, tripod positioning, which is where they sit and lean forward with the mouth open and tongue protruding. It also is characterized by drooling and difficulty swallowing, inspiratory stridor, mild hypoxia, and distress. Therapeutic management includes prevention of progressive respiratory obstruction and possible intubation or tracheostomy. Acute laryngotracheobronchitis, or LTB, is the most common of the croup syndromes. It generally affects children less than the age of 5. The organisms responsible include RSV, parainfluenza virus, M. pneumoniae, influenza A and B, and pneumococci and staphylococci. Manifestations of LTB include inspiratory stridor, suprasternal retractions, barking or seal-like cough, increasing respiratory distress and hypoxia. This can progress to respiratory acidosis and respiratory failure. LTB is usually preceded by an upper respiratory tract infection. Therapeutic management of LTB includes maintaining the airway, maintaining hydration through oral or intravenous fluids, providing a nebulized mist with supplemental oxygen, nebulizer treatments of epinephrine and steroids. Acute spasmodic laryngitis is also known as spasmodic croup. It consists of paroxysmal attacks of laryngeal obstruction. It occurs chiefly at night. The inflammation may be mild or even absent. It most often affects children the ages of 1 to 3. Therapeutic management is similar to that for infectious croup. Bacterial tracheitis is an infection of the mucosa of the upper trachea. It is a distinct entity with features of croup and epiglottitis. Clinical manifestations are similar to those of LTB. It also may be a complication of LTB. It involves thick, purulent secretions that result in respiratory distress. Bacterial tracheitis requires vigorous management with humidified oxygen, antipyretics, antibiotics. There may be a need for intubation as well as mechanical ventilation. The reactive portion of the lower respiratory tract includes the bronchi and bronchioles in children. Cartilaginous support of the large airways is not fully developed until adolescence. Consequently, the smooth muscle in these structures represents a major factor in the constriction of the airway. Bronchitis, also known as tracheobronchitis, is a mild, self-limiting disease. It's caused by a virus or M. pneumoniae. Clinical manifestations include a dry, hacking, non-productive cough that worsens at night. Nursing care includes administration of cough suppressants, fluids, and rest. Respiratory syncytial virus and bronchiolitis. RSV is a common acute viral infection that usually follows an upper respiratory infection. It often occurs in the winter and early spring. It's diagnosed through direct fluorescent antibody or ELISA. Therapeutic management includes humidified oxygen, adequate fluid intake, airway maintenance, and medications. Monoclonal antibodies are used for prevention for those who are susceptible. The nurse should address the copious nasal secretions with nasal normal saline along with suction with a bulb syringe. The nurse should also offer small amounts of fluid frequently and monitor oxygen. Pneumonia may occur either as a primary disease or as a complication of another disease. The causative agent is either inhaled into the lungs directly or comes from the bloodstream. Pneumonitis is a localized acute inflammation of the lung without the toxemia that's associated with lobar pneumonia. Nursing care of the child with pneumonia is primarily supportive and symptomatic, but it requires thorough respiratory assessment. Causes of pneumonia include bacterial, viral, mycoplasmal, and pneumococcal. A vaccine was approved in 2010 for children 6 weeks to 71 months. It provides protection for 13 serotypes. Viral pneumonia occurs more frequently than bacterial pneumonia. Pertussis, or whooping cough, is caused by the Bordetella pertussis. In the United States, it occurs most often in children who have not been immunized. There is a higher incidence in the spring and summer. It is highly contagious and lasts for 6 to 10 weeks. Young infants are at high risk. Vaccines and boosters are important in prevention. Tuberculosis, or TB, is caused by Mycobacterium tuberculosis. There are the human and bovine varieties which children are susceptible to. Case rates of TB for all ages are higher in urban, low-income areas and among non-white racial and ethnic groups. Clinical manifestations vary, but they generally include fever, malaise, anorexia, weight loss, aching pains, tightness in the chest, and as the disease progresses, more respiratory symptoms occur. Diagnosis of TB is based on information derived from physical examination, history, TB skin testing, and radiographic examination along with cultures for the organism. Most children recover from primary TB infections and are often unaware of its presence. TB is a serious disease during the first 2 years of life, during adolescence, and in children who are HIV positive. Except in cases of tuberculous meningitis, death seldom occurs in treated children. Antibiotic therapy has been helpful. Tuberculosis testing. The recommended procedure is the MAN2 test, or the PPD, which stands for Purified Protein Derivative. The standard dose is 5 tuberculin units administered intradermally. For a positive reaction to occur, the induration is measured, not the erythema. Skin tests must be carried out correctly to obtain accurate results. The tuberculin is injected intradermally with the bevel of the needle pointing upward. A wheel 6 to 10 millimeters in diameter should form between the layers of the skin when the solution is injected properly. The reaction to the skin test is determined in 48 to 72 hours. Universal testing of all children is no longer recommended. Recommended drug therapy for treating TB disease in the child with clinically active disease includes combinations of INH, rifampin, PZA, and ethambutol. It is usually a 6-month regimen. It often involves directly observed therapy, DOT, which means that a healthcare worker or other responsible individual is present when medications are administered to the patient. Some presentations of the disease may be treated for longer periods. Patients at high risk might receive prophylaxis. This might be INH for a period of 12 to 20. Foreign body aspiration. Children between the ages of 1 and 3 are at higher risk. These foreign bodies might include beads, paper clips, other small objects in the nose, things like hot dogs, peanuts, popcorn, marbles, and coins. Of course, if a patient is choking, gagging, wheezing, or coughing, one might suspect that a foreign body is present. Children are often asymptomatic. A bronchoscopy would be required for definitive diagnosis. Therapeutic management would be endoscopy to remove the foreign body. For nursing care, the nurse should teach regarding prevention of these aspects. Aspiration pneumonia occurs when food, secretions, or other materials or liquids enter the lung and cause inflammation. This aspiration is a particular hazard in the child who has difficulty with swallowing or is unable to swallow because of paralysis, weakness, or debility. Classic symptoms include an increasing cough or fever with foul-smelling sputum, deteriorating oxygenation, evidence of infiltrates on chest radiographs, and other signs of lower airway involvement. Nasogastric tubes used for feeding should be checked before initiation of bolus feedings, and continuous NG tube feedings should be evaluated periodically for proper tube placement. The child at risk should be placed in a side-lying recovery position. Other substances that may cause pneumonia are hydrocarbons, lipids, solvents. Pulmonary edema is the movement of fluid into the alveoli and interstitium of the lungs. It can be cardiogenic or non-cardiogenic in nature. Therapeutic management includes treating the underlying condition, PEEP, or peak end expiratory pressure, with CPAP, as well as intubation. Nursing care of the child with pulmonary edema includes monitoring pulse oximetry, end-tidal CO2, arterial blood gases, lung sounds, as well as respiratory rate, rhythm, depth, and effort. Acute respiratory distress syndrome is an acute lung injury. It's characterized as respiratory distress and hypoxia occurring within 72 hours after a serious injury or surgery. Causes can be sepsis, trauma, drug overdose, or near drowning. Acute respiratory distress syndrome, ARDS, is due to direct lung injury or to systemic insults that lead to lung injury. The treatment is supportive. The patients may be on mechanical ventilation, but it's important to maintain oxygenation and perfusion. The mortality rates remain high. Nursing care involves intensive care. The nurse monitors oxygenation, respiratory status, cardiac output, perfusion, fluid and electrolyte balance, and renal function. The severity of smoke inhalation injuries depend on the nature of the substance, the environment, and the duration of contact. Local injury causes alveolar and bronchial damage. With systemic injury, gases interfere with cellular respiration, such as carbon monoxide and hydrogen cyanide. With carbon monoxide poisoning, the oxygen saturation obtained by pulse oximetry will be normal because that device measures only oxygenated and deoxygenated hemoglobin. It does not measure dysfunctional hemoglobin, such as that where it's combined with the carbon monoxide. Therapeutic management involves humidifying oxygen at 100% and possible intubation. Exposure to environmental tobacco smoke results in increased numbers of respiratory illnesses, increased respiratory symptoms such as coughing and wheezing, and reduces performance on pulmonary function tests. Passive smoke is also called secondhand or side stream smoke. Indoor exposure to tobacco smoke has been linked to asthma in children. These children have increased asthma exacerbations, increased trips to the emergency room, increased need for medication, and impaired recovery after hospitalization for acute asthma. Maternal cigarette smoking has been associated with decreased fetal growth and increased low birth weight. Asthma is a chronic inflammatory disorder of the airways. It involves recurring symptoms, bronchial hyperresponsiveness, and airway obstruction. The limited airflow or obstruction reverses spontaneously or reverses with treatment. Studies of children with asthma indicate that allergies influence both the persistence and the severity of the disease. There may be a genetic predisposition. Some children with asthma have no evidence of allergic disease. There is general agreement that inflammation contributes to heightened airway reactivity in asthma. Anti-inflammatory agents are key components of asthma therapy. Another important component of asthma is bronchospasm and obstruction. There is an inflammatory response, airway edema and accumulation and secretion of mucus, spasm of the smooth muscle of the bronchi and bronchioles, and this decreases the caliber of the bronchioles. Respiratory. As you look at box 40-13 in your textbook, you'll see the asthma severity classification in children for ages 0 to 11. You should also look at box 40-15 for the clinical manifestations of asthma. In general, you would see a hacking, non-productive cough, shortness of breath, a prolonged expiratory phase, and an audible wheeze. You might hear crackles, and with repeated asthmatic episodes, you might see a barrel chest, elevated shoulders, and the use of accessory muscles of respiration. The diagnosis of asthma is determined primarily on the basis of clinical manifestations, history, physical examination, and to a lesser extent, laboratory tests. Pulmonary function tests provide an objective method for evaluating the presence and degree of lung disease. They also might use bronchoprovocation testing as well as skin prick testing to diagnose the disease. For therapeutic management, the goal is to maintain normal activity levels and to prevent exacerbations. Drug therapy for asthma includes long-term control medications and quick relief medications. Many asthma medications are given by inhalation with a nebulizer or a metered dose inhaler, or an MDI. The MDI should always be attached to a spacer, especially when an inhaled corticosteroid is administered. This prevents yeast infections in the mouth. Cromolyn sodium is an example of a long-term control medication. It stabilizes. Here's an example of a metered dose inhaler with a spacer. Drug therapy for asthma might also include albuterol, metoprolol, terbutaline, long-term bronchodilators, theophylline, and with theophylline you would want to measure the serum levels, leukotriene modifiers, and other medications. Asthma interventions might include exercise where they participate in activities that require short bursts of energy, not activities that require endurance. Also breathing exercises and hyposensitization, such as immunotherapy. Status asthmaticus is a medical emergency that results in respiratory failure and death if it's left untreated. These individuals continue to have respiratory distress despite vigorous therapeutic measures. You may see a concurrent infection in some cases. Therapeutic intervention includes improving ventilation as well as pharmacologic agents. Goals of asthma management include preventing exacerbations and avoiding allergens, provide acute asthma care, relieve bronchospasm, monitor function with a peak flow meter, and then master self-management of inhalers, devices, and activity regulation. Cystic fibrosis has a multi-system involvement. There is increased viscosity of mucus gland secretions, an elevation of sweat electrolytes, an increase in enzymatic constituents of saliva, also autonomic nervous system abnormalities. Cystic fibrosis is inherited as an autosomal recessive trait. The affected child inherits the defective gene from both parents. If both parents carry the gene, there is an overall risk of 1 in 4. This chart shows the multi-system involvement that occurs with cystic fibrosis. Because of the increased viscosity of mucus gland secretion, the secretion results in mechanical obstruction. The pancreas and respiratory tract are predominantly affected. All of the states require newborn screening for cystic fibrosis. The sweat chloride test is used for diagnosis. The normal sweat chloride content is 40 milliequivalents per liter. A chloride concentration greater than 60 milliequivalents per liter is diagnostic for cystic fibrosis. In some situations, DNA testing may be substituted for the sweat test. This would allow for identification of the mutant. Clinical manifestations of cystic fibrosis include wheezing respiration, dry non-productive cough, generalized obstructive emphysema, patchy atelectasis, cyanosis, clubbing of the fingers and toes, and repeated bronchitis and pneumonia. The patient with cystic fibrosis may have meconium ileus. You would see abdominal distension, vomiting, and failure to pass stools. Ultimately, you would see dehydration. They also might have distal intestinal obstruction syndrome. Undigested food may be excreted in the stool, which increases bulk, frothiness, and creates a foul odor. You might see wasting of tissues as well as prolapse of the rectum. With cystic fibrosis, you see delayed puberty in girls, sterility in boys, and the parents report that the child's skin tastes salty. Dehydration, hyponatremic, hypochloremic alkalosis, as well as hypoalbuminemia. Patients with cystic fibrosis often have pulmonary complications. They follow a chronic infection. The bronchial epithelium is destroyed. That infection spreads to peribronchial tissues and weakens the bronchial walls, and this leads to fibrosis. The oxygen and carbon dioxide exchange decreases. These complications are present in almost all patients with cystic fibrosis, but the onset and extent are variable. Lung tissue is destroyed because of the stagnation of mucus and the bacterial colonization. Tenacious secretions are difficult to expectorate. They obstruct the bronchi. Further respiratory complications occur. They result in chronic hypoxemia. This causes contraction and hypertrophy of the muscle fibers in the pulmonary arteries and arterioles. This can result in pulmonary hypertension, cor pulmonale, pneumothorax, and hemoptysis. Patients with cystic fibrosis are susceptible to infectious pathogens such as Pseudomonas, Staphylococcus aureus, Haemophilus influenza, E. coli, and Klebsiella. In the GI tract, thick secretions block ducts and cause cystic dilation, degeneration, and diffuse fibrosis. This prevents pancreatic enzymes from reaching the duodenum. Impaired digestion and absorption of fat occurs, leading to steatorrhea. Impaired digestion and absorption of protein leads to azoturia. With cystic fibrosis, endocrine function of the pancreas initially stays unchanged. Eventually, pancreatic fibrosis occurs and diabetes mellitus may result, so it's important to monitor blood glucose levels. They may have insulin resistance and insulin deficiency. Focal biliary obstruction results in multilobular biliary cirrhosis. The patient with cystic fibrosis has a pancreatic enzyme deficiency, sweat gland dysfunction, failure to thrive, and increased weight loss despite increased appetite. Cystic fibrosis requires intense respiratory management, such as airway clearance therapies, bronchodilator medications, physical exercise, aggressive treatment of pulmonary infections, aerosolized antibiotics, as well as home intravenous antibiotic therapy. Cystic fibrosis requires extensive gastrointestinal management, such as replacement of pancreatic enzymes, high protein, high calorie diets, as much as 150% recommended dietary allowance, relief of intestinal obstruction, such as an ileus, reduction of rectal prolapse, and then also treatment of chronic gastrointestinal reflux. The estimated life expectancy for a child born with cystic fibrosis in 2009 was 37.4 years. It is a progressive and incurable disease. Depending on availability of organs, they might undergo a transplant, and that would include the lung, heart, pancreas, and liver. That would increase the life expectancy. but there may be surgical complications. It is important for the nurse to provide support to the family. They are coping with the emotional needs of the child as well as the family, the need for treatments multiple times a day, the frequent hospitalizations, the need for home care, and also the implications of genetic transmission of the disease. The nurse should focus on the respiratory system, the GI system, and the endocrine system, as well as nutrition. Nurses should always be aware of the clinical manifestations of respiratory failure. The cardinal signs are restlessness, tachypnea, tachycardia, diaphoresis, except in neonates. Other early signs include altered depth and pattern of respirations, hypertension, exertional dyspnea, nasal flaring, chest wall retractions, wheezing, and central nervous system symptoms.